just talk about these some introductory concepts of corneal biomechanics. It's important to grasp these, because if you have these, you're going to understand the rest of the presentations as well in a much better fashion. Right, now the origins of the concepts of corneal biomechanics really go back almost 100 years when tonometry studies were being done. And if you recall, when in training we heard about coefficient of outflows, we heard about skeletal rigidity, that they were all essentially trying to grab that one factor that we didn't really understand very well, which is the material aspects of the tissues that we handle on a daily basis. So these biomechanic concepts really didn't take off much, because largely we didn't have an instrument to measure it in vivo, which was very important. But suddenly, with the advent of refractive surgery, they started to gain importance. And it is still extremely difficult to actually get accurate data in vivo on these factors such as elasticity and hysteresis and so on, viscoelasticity especially in vivo. But if we have a concept of biomechanics, we can probably better plan our refractive procedures, and we can also eliminate the effects of this aspect when we are measuring intraocular pressure. Now, radial keratotomy actually taught us, and as Dr. Raju said, that you can actually change the shape of the cornea without removing any tissue. And that is so important. You don't get into the optical center, you're only fiddling around with the periphery and you're changing the shape of the cornea. But how can then these changes outside the ablation zone affect the center? And this is where the biomechanics come into play. Then Munilin and colleagues showed us, of course, there was the classical algorithm that they made, which is there in all LASIK machines, that both hyperopia and myopia can be changed by doing ablation. But this is what is called as the geometric approach, where you look at the cornea as a piece of plastic. And essentially, this was a shape subtraction model, wherein you took the central part of this plastic and you removed some of it and created a new curvature. But this is not the case. The cornea is not a piece of plastic, and you cannot just, like a piece of glass, put a new curvature on it. So how does actually LASIK really work? Is it just this flattening that is being introduced as a mechanical thing? No. So the cornea should be conceived as a series of stacked rubber bands. So if you see stacked rubber bands laid across, which are fixed at the limbus, and in between these layers of stacked rubber bands are sponges, which is actually the extracellular matrix. Now the sponge has a capacity to withdraw fluid, but these rubber bands are under stretch. So what they do, they are attached at the limbus, and there's an intraocular pressure pressing it from inside, creating a stretch on these rubber bands, and so these rubber bands are compressing the sponge in between, thereby keeping the cornea detergest. And naturally, when the amount of water that can enter each one of these sponges will depend on the tension that is there in these rubber bands. The tighter you stretch them, the less water there will be, and there will be amount of thinning. So after myopic laser, what happens? A series of these lamellae in the center have been severed. So now what happens? You imagine the top part of the lamellae that have been cut. So the rubber bands on the side have snapped, so the peripheral segments relax. Now when the peripheral segments relax, what happens? In the periphery, water will swell up, because there is less, these sponges have the capacity to absorb more water, and the periphery will thicken. But when the periphery thickens and these segments move apart, what happens? These segments are cross-linked to the other segments. But that is how collagen is inside the cornea. It's cross-linked with each other. So when the peripheral segments move apart, the center flattens. So the impact of flattening that happens is due to the cross-linking between the lamellar layers, and outward force in the periphery pulls laterally on the center and flattens it. And therefore, the cornea will flatten centrally with any procedure that circumferentially severs lamellae. So if you take a myopic profile, a hyperopic profile, you take a constant depth PTK profile, or as well as any simple cutting of even a LASIK flap, without removing any tissue, you're going to have central flattening. And that is a fundamental concept in refractive surgery and in biomechanics, which is what I wanted to share. Let's go on to another very important aspect, which is intraocular pressure measurement. We're going to have, of course, a lot of detailed discussion on this, but these are quick introductory concepts. Now you look at a Goldman tonometer. What does it do? It impacts the corneal surface, and as we increase the pressure on the spring, the cornea goes into a stage of applanation. So where does it achieve? It achieves what we call steady state applanation. So you have a cornea which is completely applanated, and you take a reading of the machine. Whereas the machines which are able to measure the dynamism on this movement are actually the ones that give us a lot more on biomechanical aspects. So if you look at a non-contact tonometer, can I have a... So if you look at the air pulse, as it hits the cornea and goes up in intensity very rapidly, you find that at one point it produces an applanation, and that's where the detector signal peaks. And thereafter, of course, the cornea becomes concave, but the machine shuts off. And so you've got this applanation tonometry, and that's the pressure of the eye, which is the air pressure force, which is at that point of time. But if you look at the machines which look at the dynamic aspect, they go beyond that. They allow the cornea to become concave, and then when the pressure shuts off, they are again measuring when the cornea comes back into the flat state before it reverberates and comes back to the normal convex surface. And it is this difference between applanation pressure 1, which is when the pressure is being given, and the applanation pressure out, which is the applanation pressure 2, and this difference is what is called hysteresis, and I'll talk about hysteresis in just a minute. So this is the machine that actually does that clinically, and it has data now which suggests that it is useful in identifying various pathologies which may be of use. Some more concepts. Again, we're talking about the cornea here. Now the cornea is like an automated strut assembly which has a spring, and it has what we call the viscous damping effect, or it has the shock absorber at the bottom here. Now a spring is a device where if you compress this spring or you elongate the spring, it doesn't matter for how long you hold it or how speedily you do it. It requires the same amount of force. And if you release it, it will spring back almost instantly to its original form. On the contrary, you take a viscous device like a shock absorber, and what does it do? It's gas or fluid, but the resistance that it will give you is based on how quickly you compress it. The quicker you compress it, the more resistance it's going to give you, and that is called viscous damping. Now the cornea exhibits both these. So the viscous damping is pretty similar to a sponge. You take a wet sponge, you compress it, and you release it. It doesn't spring back. It springs back very slowly, or it may not spring back at all, or may spring back only to a partial extent. So that's important to understand, that the hysteresis is a measure of the viscous damping in the corneal tissue. It is the energy absorption capability of the cornea and is not strongly correlated with the intraocular pressure. The corneal resistance factor is an indicator of the total corneal response, because here we actually look at the thickness as well, and with the formula calculate this. When we talk about intraocular pressure measurements, if I asked the audience 10 years ago, how many of you were doing pachymetries routinely for your glaucoma patients? Show of hands. 10 years ago? 2. How many of you today? 3. How many of you today are doing pachymetries or corneal thickness assessments routinely for glaucoma patients? Alright, so that's more than 50%. So see the perceptual change. In 10 years, we've gone from virtually 2% to about 50% because we've realized that thickness is important. However, read these statements. The over or underestimation of IOP caused by corneal interference is only valid on average, and the relationship is not very significant. And glaucoma opinion leaders caution against using only thickness-based IOP correction algorithms, and adjusting IOP by means of a fixed CCT algorithm is almost certainly wrong in the majority of our patients, and is attempting to instill a degree of precision into a relative flawed instrument, which is the golden tonometer. Look at the plot between in a normal population of the corneal thickness and the corneal hysteresis. No relationship whatsoever. So the hysteresis is independent of thickness. So the thickness may vary from 450 to 650 microns, and you have a huge variation in the corneal hysteresis. So it's a concept of the material of the cornea that's important. The corneal hysteresis is independent of intraocular pressure. Again, you look at this plot and you'll find that there's very poor correlation between the intraocular pressure and the corneal hysteresis. You have a patient with a population with 15 milliliters of pressure with a hysteresis of a huge margin from here to here. Similarly, CCT versus CH, the correlation is rather poor. But if you compensate for this hysteresis change and then plot this and what we call the IOPCC, which is the intraocular pressure compensated for cornea, you find a beautiful correlation across the board regardless of the thickness of the cornea. You have a very good line where the correlation is very good. So what it tells us is that thickness is not resistance. If I take a piece of pine wood and I put a pressure on it, it will bend. If I take the same thickness of oak wood and put the same pressure on it, it will not budge. So it's not thickness alone that matters, and this is why the importance of not just doing a thickness-based change or on your intraocular pressures. So IUPCC correlates strongly with the Goldman on average, but it has the advantage of not being affected by corneal thickness and by these other corneal biomechanical properties. Look at patients with normal tension glaucoma. They're all, this blue line is on the IOP measured by the Goldman, and the pink line is the one measured by IOP-CC, and you see it's significantly higher. So all these patients who we call normal tension glaucomas may not be normal tension glaucomas. They're actually regular glaucomas, only we are under-recording their pressures. So if you look at the sensitivities and specificities, you find that there is about 72% of these patients who were thought to be normal tension glaucomas have now been reclassified as normal high tension glaucomas. Look at what happens after LASIK. This is Goldman tonometry. There's an average drop of 26% on the intraocular pressure. But see what happens to IUPCC, virtually no change. So after LASIK, virtually every tonometer that we have is useless, because it doesn't give you an accurate assessment. Refractive surgery problems, same thing. We are looking at leaving a minimum residual bed, but we all know that there are patients with 350 plus microns of residual bed who have had ectasia. Why? Because thickness is not strength, and this is being re-emphasized here. So you may have soft corneas, which may require a larger residual stromal thickness than normal corneas, and you may have a concept of hard corneas, which may be able to tolerate more than what the suggested guidelines would allow. Look at this plot size, for example. There is a plot where these red dots are the average pre-operative hysteresis, and these are the average post-operative hysteresis in the LASIK population. But you look at patient here has a pre-operative hysteresis value which is even lower than the average post-operative hysteresis value. That's the one you need to watch out for, because he's the one who's a likely candidate for developing ectasia. Look at how we classify corneal pathologies. This is the normal population where we have hysteresis value between around 11 and 12. And you look at keratoconus, which is a population of thin corneas, and Fuchs dystrophy, a population with thick corneas. But they both have low hysteresis. They both have corneas which will not respond in the appropriate fashion when treated. The signals are the corneal signature. These are the signals we get from these machines. And lastly is the importance of the clinical relevance. We can detect corneal pathologies, identify ectasia suspects, look at the progression in glaucoma, because corneal hysteresis, if it's low, it's an independent risk factor. And of course, IUPCC is a much better machine to have. A machine that gives you IUPCC is much better than one that doesn't. So thank you so much, and I'm going to now invite, I think it's Dr.